This is an interesting title, isn't it? And I never kind of choose the title of my talk. I think Ellie sets herself a challenge every year to come up with a title that really makes me think and think about what I might be able to say to you that would, A, would be interesting, and that B, may have something vaguely relevant to leg ulcers. So I hope you'll find this interesting. And as always, I thought I'd better have a look at the literature and see what's written about the art of science. Now, those of you who know me or who were in the workshops with me yesterday will probably realise I'm quite a practical person. If you give me a choice about research, I'll always go for the quantitative over the qualitative. I love reading the patient stories. I just find the theoretical frameworks that go with qualitative to be something that makes my head hurt just a little bit. So reading definitions like this for me is always a challenge, particularly pulling out things that I feel are practical and pragmatic. And I'm sure you've all heard of Hildegard Peplow, and most of you have worked with her theories during your nursing practice. So when I looked at this, I thought, well, I can kind of get with this, and that it's two concepts that have particular meaning. And much as though I'm pragmatic, I do understand that there's a difference between what we do and how we think and feel and what goes behind things. And I agree very much that having a comprehension of both of them is fundamental to what we do. I also think that the majority of nursing is very complex. A lot of it is about as much of what we don't do as about what we do, because it's identifying what's relevant for that patient you're with that makes a difference. So she identifies these three major components that are important to us and talks about systematized knowledge. And part of what we have been doing in the Welsh Wound Innovation Centre has been about trying to systematize things, trying to put pathways into things, to standardize things. And that's not about reducing nursing input or about making things cheaper. It may be about making them more cost effective, but it is about making them more effective. Because quite often, I'm sure you all know, the most common cause of error is human error. No matter how hard we try, we are fallible. And I don't know about you, my memory's not as good as it should be. I'm sure I've told somebody something, I'm sure I've sent an email, and I go back to my computer and I find I sent it to Trudy, who'd told me about the thing that I was going to send, rather than the person I'd addressed it to. So the email said dear, but the address was Trudy. Or that I forgot to press the send button and it's in my draft file. So having processes and systems are good, it helps us. And I've heard a lot these 2 days about the processes of the leg club and about the data capture and how you follow all the same things. But I hope at the end to bring it back to the other part of what's important about the leg club, that delicate balance about the experienced nurse and the experienced patient. So in terms of what it means for our daily practice, I think fundamentally it's about the best quality evidence and guidelines. So as clinicians, whether you're a nurse, a podiatrist or a support worker working within a framework, that what we do is based on high quality evidence. But I think there's a flip side to that, because we also have a responsibility to generate good evidence, to generate data that improves the care that we deliver. Because we all know that some of the evidence isn't out there and that not everything can be inquired about by a randomised controlled trial. Some of it has to be developed from experiential knowledge. And a lot of that is about the patients, because if you've ever read a randomised controlled trial, I'm sure one of the most important things you identify is that the patients are probably not like yours. The patients are all in this very tight box of patients who do what they're meant to do and who haven't got lots of diseases. And the only way you learn to adopt and adapt is by thinking about patients as individual and thinking about situations that are individual. And this was really apparent in the workshop that I was in yesterday, when I was asking people about, what were things that impacted on a wound being simple or a wound being complex. There was a lot of discussion about patient factors, and particularly about the patient's attitudes, the patient's behaviours, and how that impacted on what we did. And that brings me around a little bit to the non-concordant patient. And I know through most of my qualified practice, I've heard other nurses, and I've probably been as guilty as every nurse, of talking about the non-concordant patient. And Mary Rose said to me yesterday, what does that mean? So I had to say, well, we used to say non-compliant, and then we went to non-adherent, and now we say non-concordant, and it is a transition from the medical model of you must do as I tell you to it's an engaging situation where you should work with the patient to find out what it is that works for them, and you should have an agreement about what your outcomes are. And in many ways, I think that getting concordance from a patient is an art form in itself, because patients, the majority of patients like to please us. So actually finding out what the problem is and why they're non-concordant is a very big challenge from time to time, because they sometimes won't reveal because they may feel foolish or they don't understand themselves what the issue is. And I think the example I always give of this is from very, very early in my days as a tissue viability nurse. We were using a set amount of alternating mattresses. We had them in the community and in the hospital. And I was called to one of my outlying hospitals to see a lady who came in regularly for respite care. She had an alternating overlay in her home, which she used to bring with her. It was, every time she came in, she brought with her. But it was due for a service. So we said, well, we've got spare, have yours serviced while you're in, and then, you know, it's not an inconvenience. So that was the plan. She came in, and I got a call from the ward in the afternoon saying, you have to come and talk to her. She's refusing her mattress. We've all tried, you know, the staff nurse had tried, the sister had tried, the doctor had tried. She's now sat at the side of her bed. So you can picture this elderly lady. So she's sat at the side of her bed with a handbag like this on her knee. So you all know what that means, don't you? This, I've made my decision. You will not change it. She's going home. So I went up thinking, oh, I'm not sure what I'm going to say that's any different. And her first words were, I'm sorry they've called you, they've wasted your time. I feel so guilty. So I sat with her for a little while. She cried. She was very embarrassed. And after about 2 hours of holding her hand, just chatting to her about other things, eventually what transpired was we had slightly newer mattresses than her one. Okay? And our mattress had a green cover. And she was very superstitious. And if any of you know anybody who's superstitious, you'll know green is unlucky. And she thought if she had a green mattress, the only way she'd leave the hospital was in a box. So we gave her a blue mattress and she stayed. But the ward staff had not been able to get that information from her. And some of that was she perceived they were busy. There were other patients, whereas I told her I hadn't got any other patients. I was meant to be having an admin day and let's sit and chat. And eventually it came round. And I think with a lot of patients who are non-concordant, there is usually a reason. It's painful for them, it doesn't fit with their life. There's something about it that we don't quite get to the bottom of. There will always be patients who are just bloody minded. You know, we can't get away from that. But there is usually a reason, and I think for many of us, that is where the art of nursing comes in. And sadly, it's something that we feel we have less and less time. Would a lot of you say that you feel you have less time to engage with patients on that level, to give them the time that you know it needs to find out what the problem is? And almost you kind of take a short-term gain if you spend less time with them, but long-term you maybe lose out on that. So the most common reasons, I think, for non-concordance are often around lack of knowledge or understanding. And I've certainly met patients who I've given a long explanation of something, they've nodded and told me they understand, they've repeated back what I've said, and then I see them the week later and ask them a question differently, and it's very clear they've got no idea what they're doing. And there are all sorts of strange examples. A colleague of mine who's very well known in the leg ulcer field went to visit her mother who has a leg ulcer and had a tablet strapped to her toe with a piece of micropore because the doctor told her the tablet was for her foot. And she has early stage dementia, so she put it on her foot. So whose problem was that? Was that the patient who got it wrong, or was that the clinician who got it wrong? Some people just can't comply. If you ask them to do things, you have to be sure they can do it. Does it fit into their routine? Can they, particularly the arthritic patients, can they do the bending or whatever it might be? And is it a priority? How many of you have started a new diet, a new fitness regimen, whatever it may be, and done really well for 3 or 4 days, and then, you know, had a day it didn't fit? Did any of you do the 5-2? Is that what's called 5-2? Yes. How long did it last? Until you had an event, until there was a wedding or a birthday, or you were going away, and then you come back and you just never re-pick it up, do you? So we have to remember that our patients are exactly the same. We can also think about this, about the way nursing has changed and the delivery of clinical care has changed. I'm old enough to remember the days when everything was about a task. You had a book and you ticked things off, and every 2 hours you went round with a trolley and you did a back round. Strangely, we seem to be back there, don't we? It's called something different, it's called intentional rounding, but we still seem to be back there. And that was stripped away as being non-holistic, not taking care of the patient, being focused on the task. It certainly was quicker, but it's a huge amount of resource consumption. I've been at a conference earlier this week looking at telehealth and telemedicine, and I was kind of sent rather than chose to go. So I kind of went with a humph and a bit under duress. It was really interesting, looking at how they can use telehealth to improve things. And the one presentation that really stuck in my mind was a data company who were working with pharmacists and meds management in nursing homes. Now, if you work in a nursing home or you go into a nursing home or a residential care home, you will know that medicines are delivered not in the same way as in a hospital, and that patients don't wear armbands, so there's no way of checking other than asking them. And that a lot of those patients are on many, many medicines, and they've come up with kind of a system where when the drugs come in, you scan the barcode on the box, and you scan the box you're putting it into, which is the patient's own box, which has their picture on. Then when you do the medicines round, you get their box out, you scan the box, it shows you their picture, so you can check you've got the right patient. And then as you get the medicines out, you scan it, and it will tell you if it's the right medicine for the right time for the right patient, which I thought was amazing. And then it will also say, and you've only got 48 hours worth left, order some more. Now, to me, that's a real science. And I got very worried about, they said that support workers were giving medicines, but it's a care home. Why wouldn't they? If you're in your own home, don't you do your own medicines, or a relative do it? And isn't this a safer way? And the kind of checking they could do behind that, the reports they could generate just at the press of a button about medicines given at the wrong time. And it also would alert you if you were doing a round and you'd done this patient last on the 8 o'clock round and you went to do them first on the 12 o'clock round, well, you know the gap's not very big. It would alert you to tell you that. So it's doing some really good technical things, but it's very task orientated. But doesn't that allow you the time to spend a little bit more time with the patient on working out what goes wrong with them? They also told me, because I said it doesn't stop the patient putting the tablet down, does it? Or dropping it down their clothing, or it's still on the knee or wrapped in a tissue. And apparently there's a drug now that's got some kind of thing in it that by Bluetooth tells you when it's reached the gut. It's very clever. So the other part of art and science is the role as a mentor. And I think mentoring is something that I remember as being a frustration. I've got to mentor another student, and it's all about paperwork, isn't it? If you're a mentor, a level 1 or a level 2 mentor, it's all about paperwork. But if you think back to your time as a student, do you remember the people who mentored you well? Do you remember the people you look up to? And it wasn't about the tasks of what they did, it was about how they handled patients, how they handled the multidisciplinary team, how they behaved towards you. And it may not have been the most knowledgeable or the most academic, but they were the people that inspired you, and they still are the people that inspire you. I've recently been to Australia doing some work out there, and on the last day I was there, a lady, a tissue viability nurse, came up to me and she said, "I think I know you." And I thought, do you know when you look at somebody and think, I vaguely recognise your face, but I'm not placing it. And she said, I don't think you know me, but my mum's name was Anna Forshaw. And Anna Forshaw was a burns specialist when I first started getting interested in tissue viability in Manchester, and she was in the neighbouring hospital, and she was my mentor. And I nearly cried. And she said, hang on, and she got on Facebook and showed me this is my mum on holiday. And it was amazing. So some 25 years later, I still remember when Anna retired, she gave me all her papers. And that was really, really kind, because that was before you had IT. So the art there is about those people making an impact on you as clinicians, not just you making an impact on patients. I wanted to talk through some examples with you about things that I think are about art of nursing rather than science. And this is a thing that I always see as a frustration. We're very obsessed by hand hygiene. Do you have hand hygiene audits in your practice? We have to tick forms to say when you wash your hand, at what point of care, and they look at how many pairs of gloves you use. And I think there's a huge difference between touching a patient's skin and having a gloved hand to touch the patient's skin, but also how that's interpreted by a patient. I fully understand if you're going to wash somebody's bottom, you'd want to put gloves on. Or if you're going to be doing something as grotty leg ulcer, you'd want to put gloves on. But if you're going to wash somebody's face, what's the message that gives if you need to put gloves on? How does that patient feel? And what do they get from that? The other thing that I see in practice is we are more and more task-driven around observations. We use equipment to save time. So people get things clipped on them and observations are done and you get a printout and you just score it down. But I can remember very clearly being taught how to take a pulse and taught to take my time in taking a pulse because of all the other things that go around the aspect of physical contact with the patient. It's not just that you are counting the beat, although as a student nurse I think I was quite obsessed. Did you used to hold your breath when you took the pulse? Because you were concentrating on your watch and the counting at the same time and then trying to multiply it by 2 or 4 or whatever you did. But as you get more experience, there is a real art in that holding the patient's hand, feeling the pulse, and as you're doing that you're checking the temperature of the skin, the quality of the skin. Is it dry? Is it clammy? Are they very nervous? You can tell that. You're listening, you're feeling the rhythm and the strength of the pulse, which also tells you a lot. And you're taking that time to engage with the patient at a personal level. The patients know they need to be quiet, but in that quietness you feel some stillness in them. You feel that connection with them. Whereas if you clip them to a machine, what you get is the rate of their pulse. Now, to me, they're both very different things. Taking a pulse is something that you do with a patient and that you interpret there and then, whereas putting a machine on is just something that records a number and has a different, although not less significant meaning. So in terms of, I'm sorry, Ellie, I captured you at dinner the other night when you weren't looking. If you were going to be nursed, would you want a task-focused nurse or would you want somebody like Ellie? I know who I'd want looking after me. Would I want somebody with technical expertise or would I want somebody who actually cared about what happened to me? Now you might say if you're in the emergency department or if you're in intensive care, you want somebody who's technically brilliant. But you also want somebody who still considers that there's a you, that there is a person, and I think that's what is missing sometimes. It's okay to be technically brilliant if you're saving a life immediately. But the rest of the time, you need to remember what you're doing to the patient and what that means. And the one thing that I know about Ellie from the long time that I've known her, which is a long time, is that everything she's done around the leg club has always been because it was for the patients, because she believed it was better for a patient to be cared for in that way. And I think if we start to bring it down to leg ulcers and leg ulcer care, then certainly there's an art and science in leg ulcer care. And Trudy and I were talking about this at lunch, and she gave me a really good example, which I think I'll show you. And certainly for most of you, the science of bandaging is a science, isn't it? It's a real technical precision thing. It's a thing you learn. Do any of you still do a bit of a stretch and a feel with a bandage? You kind of almost do it with your eyes closed. With a particular bandage, you know that that's the right amount. You don't need to look at squares or circles. You know once you do it a lot. But also as part of the assessment and part of the bandaging, that's actually a significant period of time you are spending on a one-to-one with a patient, because you have to do it like that because that's how long it takes. And there's an awful lot of both verbal and non-verbal communication that goes on during that period that you can learn a lot about the patient. So for example, this may be the first thing you see of the patient, and this is not the worst pair of legs you've seen, is it? If you work in leg ulcer care, this is your daily bread and butter. But for a lot of people, that's actually something that may be quite revolting or disgusting, or they may be ashamed or embarrassed about. So when you take their bandages down, how many times have you seen a patient who is tense or who says to you, "Oh, my ulcers are terrible, nurse, they're probably the worst you've ever seen"? Have you heard that phrase? And actually they're only this big. And I'm really sorry that my feet are dirty, and I have put clean shoes. All the excuses, the things that the patient says to you are about their anxieties around this. And your role in that, the art for us, is about the reassurance, the absolutely blasé, this is fine, I'm not upset by it. Although there are times when you have to leave the room on a regular basis because you just need to breathe a little bit and get some fresh air. And again, I'm sure you've all been in that situation where you've taken the bandages down and you've had to really control what you're doing. But for the patient, we can't do that. We have to keep the same calm exposure and be fine. Now, I mentioned bandaging, and I found this picture in my files of patients that I'd come across, and I'm very bad at taking pictures of people with things that I think are not quite right. Would you all agree this isn't the best bandaging? It may have started out all right, but I don't know. That may have been that the patient's edema had reduced considerably and the bandage has fallen down because of that. It may be because the bandage was applied very badly in the first place. But would any of you, if you saw that, feel proud of the care you have delivered? And this is what Trudy was talking to me about. However, there's something very satisfying about a figure of 8, isn't there? When you put a figure of 8 on, how many of you do this down the leg, shimmy your hands down the leg, and stand back slightly to put your things in a line? It's something you're proud of, isn't it? It's a technical skill, but it's also something that we take pride in achieving the right delivery of that thing and the right outcome for the patient. And of course, if you do it properly, then you know you're going to get a better outcome. So I hope from the examples I've given, what you can see is that the art and the science are complementary and not opposing forces. So you can be technically good as well as being artfully good. And during my academic career, I've heard many times people say that, oh, she's not very academic, but she's a very good nurse, which implies that you can't be both. And some people are not academic, and some people don't have a good writing style. And a lot of academic work is purely stylistic. Once you understand what people want you to write and you can follow the pattern, you're doing okay. And I would rather have somebody who's not academic and is a good nurse than somebody who's academically brilliant and naturally not a very good nurse, who's brusque and who doesn't listen to what I'm saying. And I think that was my quote for the day from Gary this morning that Trudy read out to me, that you can touch but you don't feel, you can listen but not hear. And I think that for me is about the art and the science of the nursing, because if you actually did both of those, then what you're doing is important. The touching and not feeling, going back to things like the pulse and checking the skin and washing the skin, and that contact being very important. And I was thinking about, if we took this through logically, thinking again about the intensive care patient, that skillful application of science and technology certainly can improve the patient's disease state. I never did intensive care as a student nurse, and I've never worked in there. And if I ever have to go into intensive care to see patients now, I tend to stand like this, because I'm very worried that I'll trip over a piece of tubing and that, terrible things will happen. And if somebody says to me, will you just press that button, I automatically do a head shake. I will do it, but I get this kind of nervous tick. So I understand that technical nursing is really, really crucial. But it doesn't necessarily make the patient better in themselves. A kind and caring approach can make them feel better, but may not make them better. And we've talked repeatedly throughout this event and at others about patients who do not get referred into the right service at the right time. And that's kind of an example of that. So somebody's doing things for the right reasons, for the best, their best, but it doesn't necessarily mean that they've got the patient's best at heart. And that might be a lack of knowledge or a lack of competence on their part, or it may just be a lack of thought, because people are very pressured, they're under time pressured, and what they're doing is going in, changing a dressing on a daily or twice weekly basis without thinking, actually 6 months have gone and I'm still changing the dressing and nothing much has changed. I understand that a little bit more now, because I find the older I've got, I actually don't know what happened to September, and we're nearly in October, aren't we? So six weeks can go very, very quickly, but it's having that mindfulness, that state of mindfulness, to realise you've passed the time and that you should actually be reviewing the care that you've given. And for me, when thinking about the art and science of nursing, I think perhaps this is one of the best examples that I know, that the leg clubs try to work in both of those ways. And is that because there is a real human touch to a leg club? Now, I've only visited one leg club a couple of times, and what was really apparent to me when I went there was the hustle and bustle, the feeling of people knowing each other. A new patient came in who was new to the leg club, and the immediate warmth of the welcoming, the come in, sit down, can we get you a drink, would you like a biscuit? And even for me, who was taken as a visitor, I kind of felt swept in and belonged even though I was just there to kind of stand against a wall and observe what's going on. And I think that is really crucial in engaging people. And a lot of the non-concordance I talked about is about people feeling external, feeling outside. And if we can engage them in what's happening, it does make a change. So I do believe that the social model of care really switches the focus much more onto the patient and what's best for the patient, and encourages the art form. So what you see, as well as the care being delivered, is going back to what I talked about mentorship for nurses. If you deliver care as a lone carer, as a lone practitioner in a patient's home, there is no support for you. If you're unsure about a decision, there's nobody to turn over your shoulder and say, what do you think? Is this bandaging looking okay? Do you think this wound's infected? I'm not sure. And you get that in leg club. There is the support. There's also the support for the patients who I know do exactly the same thing and look at each other's leg ulcer and say, oh, I had one like that, or I've had that dressing, or that dressing was really good and it got me better quite quickly. And for the nurses in the leg club, I think the big art that they have is fitting the science of the care around the patients who behave in a much more sociable way and are much more engaged with each other. And what we're trying to do is duck around them and make sure that we maintain that technical science side as well. So hopefully I've given you some thoughts for the afternoon, and I'm conscious again it's after lunch, so you've all got that slightly quiet. I had the lasagna, was very good kind of look about you. And it's a very kind of ethereal kind of subject, but I'm happy to take any questions if there are any. Thank you very much.